Sudeepa ma'am, over to you.
Yes, ma'am. Thank you, ma'am. Good afternoon, everyone. Am I audible? Good afternoon, everyone. I am Dr. Simantika Datta, Clinical Research Fellow, PCOE MCH, Kolkata. Today, our topic for RDLS is common comorbidities in CL-HIV. Our speaker today is Dr. Soumyendranath Haldar, Assistant Professor of Infectious Diseases, STM, Kolkata. Dr. Soumyendranath Haldar is an infectious disease specialist. He has completed his MD in Tropical Medicine from School of Tropical Medicine, STM, Kolkata, and DM in Infectious Diseases from AIIMS, New Delhi. Currently, he is working as an assistant professor with the Department of Infectious Diseases at STM, Kolkata. Now, sir is taking over.
Thank you. Am I audible?
Yes, sir.
Okay, thank you. So, good afternoon to all. Today we will be discussing few aspects of management of children infected living with HIV and AIDS. So it's not possible to cover all comorbidities. So we will be discussing common comorbidities which we usually face every day during the management of this subgroup of children. So the contents are, we'll be discussing 5 or 6 topics like malnutrition, anemia and thrombocytopenia, hepatic dysfunction, chronic respiratory morbidities in CLHIV. CLHIV full form is children living with HIV and AIDS, neurological morbidities in CLHIV and other comorbidities. So, at the time of the diagnosis, it may have a variety of clinical manifestations depending on the age and severity of immunodeficiency. Like if I recall last 2 or 3 cases, one child came to us with regression of developmental milestones. Like previously the children was able to do all his works, but subsequently the children needs help during taking the food of the parents. So sometimes if this kind of things happen, there are some clues, then you should test. These manifestations may involve one or more systems and influence the clinical staging of HIV regimen as well as the treatment of these conditions. Most of the times, this child population, they are usually having the normal systems, or if in other words, I can say their cells are new in comparison to the elderly populations due to telomerase activity. So their immune system is not like the elderly population, and recovery of their immune system after ART is also to some extent different from the elderly population. This systemic involvement has a direct influence on the health status and the mortality. And any system may be involved directly or secondarily to other opportunistic infections. Like HIV is one of the few viruses which can directly affect the brain and may cause some neurological abnormalities, sparing the other organ systems. So, what are the common comorbidities in children living with HIV? So, infections are TB, bacterial infections, one kind of bacterial infections like respiratory tract infections, like urinary tract infections, like CNS infections, and second thing is fungal. Common fungi which usually infects this kind of children is Cryptococcus, like histoplasma, candida. Viral infections are common, like they more frequently suffer from the influenza or other CMV infections, and the infection may be localized or disseminated depending on the immune status of the children based on the CD4 count, based on the plasma viral load. Nutrition, this kind of population usually suffer from malnutrition. They may have wasting, stunting, or vitamin deficiencies because two aspects. One is the due to HIV, the patient may lose some muscle mass and looks very sick like that. In other way, he's not able to take the food properly. That's another aspect which may leads to the malnutrition. Gastrointestinal systems, recurrent or persistent diarrhea, this may be the initial presentation also. Oral or esophageal candidiasis, recurrent or persistent oral ulcers. Frequently, they may suffer from the aphthous ulcer also, which is sometimes points for the evaluation regarding their status. Hepatobiliary systems, hepatitis B, hepatitis C, all of you know. Hepatitis B and C shares the same route of transmissions like HIV. For that reason, there is more chances of being co-infected with hepatitis B or hepatitis C, which needs some special management issues also to be tackled of, because if the patient is having both HIV and hepatitis B co-infection, the patient should get the antiretroviral drugs, which comprises of at least 2 drugs which are having activity against both HIV and hepatitis B. Hematological systems, like they may suffer from anemia, and there are so many reasons of anemia. The patient may suffer from thrombocytopenia, and HIV itself can cause thrombocytopenia. But always it's a diagnosis of exclusion. You should exclude the other causes of thrombocytopenia. Then you can say the probably the reason is the HIV. Central nervous system, I have already discussed delayed development, developmental regression, like our last patient who presented with the developmental regressions, who also having some MRI abnormalities also. Meningitis due to various bacterial or viral agents, including TB, Cryptococcus, and HIV encephalopathy. HIV encephalopathy is, you should, if you do not suspect, then it's very difficult to diagnose as HIV encephalopathy, because in MRI there are certain changes which will give you some clue, and the close differentials is for the adult is PML, progressive multiple encephalopathy. So after taking the history and clinical examination, you should do MRI in any CNS cases, and you should remember the point that MRI is always having a better sensitivity than CT scan of brain for diagnosis of any central nervous system lesions. Respiratory system, recurrent or persistent pneumonia, bronchiectasis, sinusitis, chronic otitis media, these are the respiratory systems. Lymphoid interstitial, this is very important, lymphoid interstitial pneumonitis, we will discuss it later. Skin and soft tissue, like infections like bacterial, fungal, nutritional, dermatosis, scabies, molluscum contagiosum. So molluscum contagiosum is common in child population without HIV also, but if a patient is having some recurrent molluscum contagiosum, a giant molluscum contagiosum, then you should think probably the child will have the disease. Herpes zoster and recurrent herpes zoster is common in child population. Whenever a child should develop, will develop herpes zoster, you should monitor the patient so that the patient is developing the herpes zoster encephalitis or not, because herpes zoster encephalitis is having a very high mortality. Pruritic papular eruptions, this is common, usually affects the upper limbs or lower limbs, usually the lower limbs. It's intensely itchy, and if we are not very confident, for skin and soft tissue, you should refer the patient to the dermatologist. So first, malnutrition, a few words about the malnutrition. It is extremely common in HIV population. Infants and young children are more likely to present with the wasting. There are so many reasons for wasting. That's a vicious cycle. HIV causes malnutrition itself, and the intestinal absorptions may be reduced, and so that there is more progression of HIV and more wasting. So this is a vicious cycle. Older children who may have intermediate disease progression are more likely to present with the stunting. So for stunting, you have to measure the parameters. After that, you stand the case as stunting. Malnutrition is an important cause of morbidity in CLHIV, especially in developing world. Really, this is a challenging issue in the developing world because for the child we are providing the medicines, the antiretroviral drugs, but what we are doing for supplemental nutrition for this kind of patients. I think from NACO, I think there is no such very strong provision for providing food and all these things. So that part should be taken care of also by the local community or the local health authority. They should take care of it so that if the patient is not properly getting the nutrition, the medicines also, the efficacy of the medicines also may be reduced to some extent. So this is a very important aspect of treatment. Children with mild or moderate malnutrition may be managed on an outpatient basis, and those with severe acute malnutrition will require the admission. So be very cautious when you are dealing with the children. If the children is very sick, he may need some intravenous nutritional supplementation also. So please admit the patient under pediatrics department if you think the patient is suffering from severe acute malnutrition. So the classification of nutritional status, I am not a pediatrician, but still these are the things you should know by using the anthropometric indices: weight, age, length of height or age, weight by length or height. Nutritional status may be graded in 4 categories: normal, underweight, wasting, and stunting. And this is the score when you will stamp the case as a normal, moderately underweight, and severely underweight. In height for age, normal, stunted, severely stunted. And for weight for length, it is designated as normal, wasted or moderate acute malnutrition, or severe or wasted severe acute malnutrition. So it depends on the difference, how low it is from the standard deviation. If less than 1, then it's normal. If below 2, then it's like this, and if below 3, so this is like severe. So, what is severe acute malnutrition and what is moderate malnutrition? Severe acute malnutrition, so if you go in the previous chart, it's below 3 SD. So, wait for the height less than 3 SD and or visible severe wasting, medium circumference. How to measure it, I will discuss it later. And edema of both feet. This is very important. Edema of both feet. So, when the parents told you that my kid is having some pedal edema, please evaluate for severe acute malnutrition. Moderate malnutrition, wait for height between 2 SD to 3 SD, medium circumference is like 11.5 to 12.5, and no edema. If the parent is having pedal edema, then severe acute malnutrition. So this is the chart, and WHO weight by length or height of the chart. So I think you should keep this chart in your reality center for proper evaluation, and you should stamp the case for malnutrition. And how to determine the HD score for weight for length by height. So this is the procedure. First, refer to the reference table for weight for length. Remember to use the left side for male and right side for the female, and find the child's length or height in the middle of the chart. Wait for height SD score table. If the length of the height is between those listed, round up or round down. Length by height 0.5 or more centimeter greater than the next lower or height, round up, otherwise round down. So up and down, this is you should do according to your convenience. Look at the top of the column to see what the child HD score is. After that, you should put the kid where the kid lies. Is it in the normal? Is it in the moderate, or is it in the severe acute malnutrition? The child's weight may be between 2 SD scores. If so, indicate that the weight is between these scores by writing less than. For example, if the score is between 1 to 2 SD, right, minus 1 SD. It's not moving. Sorry, it's not moving.
Lucifer sir, just click anywhere on the slide and then next. Yeah.
I'm here, ma'am.
Okay. So how to measure the mid or upper arm circumference? It is first you identify where is the tip of shoulder, then you identify what is the tip of elbow. So after identification, place the tape at the tip of shoulder and tip of the elbow. Then mark the midpoint where you should measure the mid-arm circumference. Then properly tight the tape. Otherwise, you may get a falsely low or falsely higher value. And after that, you measure it like mid upper arm circumference. So it is a 3 color code is there: green, yellow, and red. For the if it is more than 12.5, then it is well nourished. It is in the green. If it is 11.5 to 12.4, it is yellow, moderate acute malnutrition. And if it is less than 11.5 centimeter, it's severe acute malnutrition. So by looking only, you will be able to identify whether the kid is having severe acute malnutrition or not. So how to check wasting or severe wasting? First, look at the front of the child and decide, is the outline of the child's ribs easily seen, like this kid. See, the ribs are very easily seen. And the skin of the upper arm looks loose. See, it looks loose. And does the skin of the thigh looks loose? So please examine these 3 points. If all are positive, then probably the child is suffering from severe acute malnutrition. And then look at the back of the child and decide, are the ribs, shoulder bone, spine easily seen? In this case, it is yes. Is there any wasting seen in the buttocks? See, all these is present here. So after that, the check for the bilateral pitting edema. Previously, I told you this is very important. Edema in the severe acute malnutrition starts from the dependent part. So feet in a mobile child. For that reason, you should examine the feet. As the severity of the edema increases, it extends to the legs, and in severe cases, it may also be seen on the upper limb and face. So this is very important. And to check for edema, grasp both feet like the procedure is like this. Grasp the both feet in your hand. Just press on the top of each feet. Thumbs gently press with your thumbs for a few seconds. And if the PD edema remains in both feet, then you lift your thumbs. So like the second picture, it clearly shows that this is there is a dip in the foot. So what is the management? Assess for their feeding practices and underlying medical conditions. I previously, please ask them and please tell them what kind of food they should take according to their convenience, what they can afford. So this is very important, and please give some time regarding the counseling regarding the nutritional aspect also. Otherwise, only by giving medicines won't solve the problem. Counsel mothers or caregivers so that they can give feeds in adequate amount, frequency, which had adequate energy density and hygiene. Counsel for food diversity and active feeding follow-up after 15 days. See, all parts of our country is not having the same food habit. So what kind of food is easily available to that particular family? What kind of food they can afford? First ask them, and accordingly you tell them they should utilize the advice from the ART center. Underlying medical condition is identified. They should be treated to refer to the higher center. And if no underlying medical condition is identified, you should counsel mothers for giving appropriate feeds for the age. So before giving the food advice, please check for these things. It's not very common. Cleft palate, congenital heart disease, infections. Because if you are not treating the infections, the appetite will be increasing. So regarding the management part, independent additional criteria, no appetite, medical complications, this is a simple thing. And discharge criteria is reduced edema, good appetite. This is very important. And intervention, this is mentioned there. So I think if the patient, this kind of patient should be admitted in the hospital, and supervised treatment is needed for care of these patients. So what are the indications? Presence of any emergency signs: hypothermia, edema, persistent vomiting, very weak apathetic, fever, fast breathing, and chest indrawing, extensive skin lesions, diarrhea, dehydration, severe anemia. purpura or bleeding tendency, evidence of systemic infections or complications, clinical signs of secondary causes of other malnutrition. So second part is anemia and thrombocytopenia. So it's a condition where the number of red cells is insufficient to meet the body's physiological needs. This is very important. And the definition, the cutoff for hemoglobin level is separate for the different age groups. For 6 to 59 months, it's less than 11. For 5 to 11 years, it's less than 11.5. And more than 12 years, as shown, it's 12.0. So anemia is present in a large population of HIV, and cause of anemia is diverse for this kind of populations. Even the previous topic, malnutrition may lead to anemia. The retrovirus itself can lead to anemia. The drug which is used for treating HIV that can cause leads to anemia. So the causes are diverse. The important causes are anemia, chronic disease, and nutritional deficiencies. In the patients of ART, zero-body may cause anemia. So mainly there are, if I go by pathology, there are two reasons: decreased production and increased loss or destruction. So regarding the decreased production, it may be due to the iron, vitamin B12, folate, erythropoietin deficiency. Some infections infects the RBC and leads to anemia. Commonest is malaria in our population, apart from this Kala-Azar, but Kala-Azar is endemic in some parts of India like Bihar, Jharkhand, like UP to West Bengal. So there are some pockets of Kala-Azar. So if a child is coming from that area where Kala-Azar is endemic, you should exclude Kala-Azar in a patient who is having anemia, persistent anemia. And the patient should have some splenomegaly also. HIV, CMV, Epstein-Barr virus, although these are not very common cause. Parvo B19, TB, yes, any chronic infection, inflammation may lead to anemia. And sometimes the TB may involve the bone marrow also. So in that cause, you may get anemia. MAC, histoplasma, yes, histoplasma usually presents with pancytopenia. And the child may have some skin lesions, which are the clue for that thing. You should think of it and treat it. If it is a case of progressive disseminated histoplasmosis, the diagnosis is not very difficult. If you do a urinary antigen test for histoplasmosis, you will be able to make a diagnosis. So the drugs which usually used in this population is giroctocin, cotrimoxazole prophylaxis. You know, there are certain indications for cotrimoxazole prophylaxis. It may lead to anemia, amphotericin B, anemia of chronic diseases, malignancies, increased loss or destruction, hemolysis, autoimmune hemolytic anemia, although it is not very common. Pre-existing conditions like thalassemia. Thalassemia is, you should exclude thalassemia if it presents with like anemia. But there are certain clues like the hemoglobin will be microcytic, hypochromic, or normocytic. Accordingly, you do some investigations. First you see the RBC morphology and reticle. Accordingly, you suggest some investigations for the etiology of anemia. GI bleeding, hypersplenism is also one reason. Evolution for anemia, children usually present with easypatability, irritability, anorexia, pica. You know all these things: dyspnea on exertion, palpitation, and need to elicit the following history. History is very important. History will guide you what kind of investigations you should do first. Blood loss like epistaxis, melena, pardactyl, bleeding due to anal fissure, menstrual losses in an adolescent girl, chronic diarrhea, recurrent jaundice, drug intake, anticonvulsants, zero-body cotrimoxazole I have previously described. Past history, chronic infections, liver and renal disease should be ascertained. Family history is very important. Like for thalassemia, if there is some history of hemolytic anemia, you should search for that. Recurrent jaundice may be there, bleeding disorders may be there, severe anemia in the family, there are frequent blood transfusions. So these things are very important. Whether the child, any of the family is having some hemoglobinopathies or not, that is very important. Dietary history, most common cause of anemia is nutritional anemia, and type of meal given after birth and age at which complementary food are introduced. You should ask all these questions. And history of pica, which increases the risk of helminthic infections. Yes, you know, but nowadays what is happening? Our country is going through some programs where the children, they are getting some anthelmintic therapy like albendazole, ivermectin. So nowadays the prevalence of helminthic infections in our populations is reduced day by day. So it's not a very common cause of anemia nowadays. Examination, general head to toe examination is essential to look for the signs of anemia, vitamin deficiencies, lymphadenopathy, splenomegaly. You should, during examination, first you think what may be the probable cause of anemia. Accordingly, you examine the patient. Presence of jaundice, tachypnea, tachycardia, hepatomegaly. But when you are examining the patient, one thing is very important. If the patient is having severe anemia, the patient may have some signs of heart failure also. So please look for the heart failure, the signs of heart failure. The signs of right heart failure is engorged pulsatile jugular venous, jugular vein, JVP. There may be tender hepatomegaly, there may be pedal edema. If there is left heart failure, there may be basal clefts, there may be pulsus alternans, there may be gallop rhythm. So please exclude all these things when you are examining a patient who is having anemia. So what are the investigations you should send? It's CBC, hemoglobin value confirms the diagnosis of anemia and its severity, peripheral blood smear, microcytic anemia, macrocytic anemia, normocytic anemia, and your investigations should be like this, like a patient who is having microcytic anemia. Don't send vitamin B12, so it's useless, or folic acid. And reverse, when a patient has macrocytic anemia, don't think of like thalassemia, iron deficiency anemia like that. So is send investigations according to the RBC morphology and retic count. Retic count, increased retic count happens ongoing hemolysis or non-chronic blood loss. Low retic count happens bone marrow depression. So this is very important. Components of management of anemia: deworming, iron folic acid therapy, nutritional counseling. All these things are very important. All CLHIV needs to be dewormed once in 6 months. So this is important. I think also some national program is going on. So I think they are getting it. And the administrations of tablets of syrup albendazole 200 mg single dose for children up to 2 years of age, and more than 2 years 400 mg. So this is important. Iron, please make note that the dose and duration of therapy should be maintained for children who is having iron or folic acid deficiency, because persistent iron or folic acid deficiency may result into stunted growth or other manifestations also. So even after correction of anemia, you should continue for another 2 to 3 months for the iron storage. And folic acid at a dose of 100 to 200 microgram per day is adequate to treat the associated folic acid deficiency. Nutritional counseling, it's very important. This kind of foods they should take and counsel the parents regarding the nutritional aspect. And when you should refer the patient to a pediatrician. If the kid is having severe anemia, hemoglobin less than 7, then the child may need blood transfusion. If any features of congestive heart failure I have previously mentioned, those with megaloblastic anemia or pancytopenia on hemogram, with clinical features of hemolytic anemia and lymphaticular malignancy, though not responding to hematinics, for evaluation of this patient, they need hospital admission. Thrombocytopenia is related to the HIV, and we should say when the count is less than 1 lakh, we should say it's a case of thrombocytopenia. Immune-mediated platelet destruction may happen also, TTP, impaired hematopoiesis. These are the reasons, and bone marrow studies are needed for evaluation of the cause. Management is usually the same as in HIV and non-infected children. Once the causes like malignancy and aplastic anemia ruled out, most CLHIV mild thrombocytopenia will respond to ART itself, because most of the time, if you are able to exclude all the causes, probably the reason is HIV, and if you get adequate ART, then the kid will respond to ART, but it's not very dramatic. Slowly will respond to antiretroviral therapy. And all children with thrombocytopenia need to be referred to a pediatrician for the evaluation. So the hepatic dysfunctions, what are the hepatic dysfunctions? Hepatomegaly or mildly elevated liver enzymes are common in CLHIV. Chronic or progression of liver disease is unusual, and in comparison to the adult population, because in adult population there are so many reasons like alcohol consumption, like other steatohepatitis, NASH, there may be some autoimmune hepatitis. So these are the reasons mostly happens in adult population, but for child population, the reasons are hepatitis A to E infection, that is hepatitis A, hepatitis B hepatitis C and E infections. Sometimes B co-infected with the D. CMV infections, Epstein-Barr virus infection, co-infection with the MAC or Cryptosporidium. MAC is Mycobacterium avium intercellular. It usually happens, usually affects the lungs, sometimes in presence with chronic diarrhea also. Fatty liver and drug toxicity. This is very important, and one of the, if you are able to exclude the causes of hepatitis, this is the second most common cause in child population, drug toxicity, because they are getting so many hepatotoxic drugs. So this part should be taken care of. So in the history, we should ask whether the kid is having any history of jaundice previously, the kid developed or not, anorexia, nausea, vomiting, fever, right hypochondriac pain, pruritus, and pale colored stools. These are the pale colored stools are indicating of obstructive jaundice. Then the examination part, icterus, hepatomegaly or decreasing span of liver span, altered sensorium, irritability, altered sleep patterns, poor feeding, ascites, and bleeding manifestations. These are the examination points you should search when you are thinking that the patient may have some liver disease. And investigations which you should send for a child with hepatitis, usually the patient with either rise in serum bilirubin or rise in serum ALT or AST. So if it is higher, then peripheral blood smear for malaria, you should exclude the infective causes, HBsAg, HCV, basically it's anti-HCV. So when you will be writing the test, write blood for HBsAg, blood for anti-HCV, IgM against HAV, and IgM against HEV virus. So you should write like this, because sometimes the lab confuses what you want. Either you want antigen or antibody. Like for HBs or hepatitis B, we need to test the antigen, HBsAg. For other viruses like hepatitis A, hepatitis C, hepatitis E, we examine for the antibody. Blood glucose testing, prothrombin time, because the decompensated liver disease, they may have rise in prothrombin time, rise in iron, and these are the prognostic markers also. So if a children having jaundice, rise in serum SGOT, SGPT, having increased prothrombin time or iron, probably the kid is very sick, and you should admit the patient in pediatrics department. Electrolytes are important. So the presence of jaundice is indicative of an acute hepatitis. It is essential to gauge the severity of the dysfunction, and is there hepatic encephalopathy or pulmonary. So if the patient is having coagulopathy manifested by rise in PTINR, or if there is hepatic encephalopathy, please admit the patient and evaluate. Treatment: remove the potentially offending medication. First, you exclude the viral etiology, then you see the green book. What kind of medications the child is getting. Like yesterday in our Sasab center, we got a child who is having rise in SGOT, SGPT in the tune of 150 or 170 like that. And during the evaluation of the kid, we have seen as the kid was having oral candidiasis and the CD4 count was less than 100, so the child was getting fluconazole, Ceftran, and antiretroviral therapy. So ALD he was getting. So among these drugs, both the fluconazole, Ceftran, and dolutegravir, all of them are capable of doing a rise in serum SGPT or SGOT. So titrate the dosing, or according to your suspicion, you may give us some like 5 to 7 days drug holiday to see whether which one is the offending drug. If the child is on ATT, institution of modified antiviral regimen, this is very important. You see what kind of infection the child is getting. See, if the patient is having some tubercular meningitis, that's a life-threatening situation. So you should not stop it. So if the standard regimen is HSZE, if the patient is having some transaminitis, substitute the drugs like the hepatotoxic drugs are pyrazinamide, ionase, rifampicin. You may start with amikacin, levofloxacin, and ethambutol because all are not hepatotoxic. So titrate accordingly. Like a kid who is having some limnotuberculosis and developed a severe transaminitis, you may stop the drugs for a few days because if it is a localized disease, you may wait. But if it's a life-threatening disease, change or substitute with the other antitubercular drugs. Supportive care is needed. For hepatic failure, monitor intestinal decontamination, lactulose or neomycin, low protein intake, vitamin K, FFP, antibiotics. It's according to your need. You give these kind of medicines. Like if a patient is having spontaneous bacterial peritonitis, you should give some antibiotics. Presence of hepatitis and CVIT and etiology influence the initiation of ART as well as the drug regimen. It's a big chapter. If a patient present to you with decompensated liver disease, what will be the regimen of the anti-HBV drugs? Whether you should give Ceftriaxone or not, whether you should give Fluconazole if needed. So these kind of the separate issues, we should discuss it later in some other day. So after that, chronic respiratory morbidities in this subgroup of population, bronchiectasis is common. Bronchiectasis is a disease characterized by irreversible abnormal dilatation of the bronchi. This is very irreversible. This word is very important. Bronchiectasis is classified as WHO stage 3 disease. Persistent cough and fever with productive purulent sputum or hemoptysis should arouse the suspicion of bronchiectasis. And clubbing is usually present, and you should ask the patient whether the patient is having past history of tuberculosis or not, because in our country post-TB bronchiectasis is very common. It is more common in adult population, but in pediatric population also it's common. Chest examination reveals localized signs which don't usually resolve with the usual antibiotic treatment. This is very important. So, like viral infections or bacterial infections leading to consolidation. So these kind of infections will usually the signs will go off after adequate antibiotic therapy. But if it's still persisting, then you should think of it. Chest X-ray may show the cystic spaces, occasionally the air filled levels and honeycomb. So what is the management? Acute exacerbations need to be treated with adequate antibiotic therapy 2 to 4 weeks and postural drainage of the sputum. Antibiotics should be carefully chosen to cover a broad spectrum microorganisms, including gram-negative bacteria. But after getting the organism by sputum culture, you should de-escalate. This is very important. Now we are going through the antimicrobial stewardship program. So, if like you have got the bug as Streptococcus, and the Streptococcus is most of them universally susceptible to amoxicillin. So there are some few case studies where the resistance is increasing. Still, it is less than 5 to 10%. So de-escalate the medicine after getting the culture report. Attempts should be made to isolate the organism by sputum culture. The treatment involves the administration of antibiotics during acute insolution and the bronchodilators. Bronchoscopy, basically you see how sick is the patient. If you are getting something in sputum, no need a bronchoscopy. If it's like the extensive lung lesions and you are not getting through sputum, then you should do bronchoscopy for getting the organism. Surgical treatment is necessary in few isolated cases where severe or refractory to the medical management and the disease is limited. This is very important. If it is extensive, there is no point of surgical treatment. It is localized to a particular lobe, then there are chances of you should refer the patient to CTDS. LIP, this is very important, and this is one of the non-infectious cause. So presents with like pneumonia, but this is non-infectious cause. So it is a diffuse infiltrates of CD4 lymphocyte, plasma cells, and histiocytes in the alveolar septa along the lymphatics. Most common in children infected with HIV, especially those aged more than 2 to 3 years. Usual insidious onset. The patient, if the child is coming with persistent, progressively worsening cough, that is very important. With exertional dyspnea, breathing difficulty, and associated clubbing, then think of LIP. And if the chest X-ray findings persist or worsen despite appropriate antibiotics, this is very important. Like the previous one, the signs are persisting after antibiotics, think of bronchiectasis. If the clinical signs are persisting, chest X-ray findings are persisting even after antibiotics and antitubercular treatment, think of it. But regarding antitubercular treatment, please be very justified after giving the, because in child population it's difficult. They are not able to produce the sputum. Sometimes gastric levels to some extent helps. So it sometimes becomes very challenging for diagnosis of pulmonary tuberculosis in child population. Treatment of LIP includes the bronchodilators and short course of corticosteroids with long course and slow taper with the chronic cases. So while evaluating a HIV-infected child with respiratory symptoms, it should be remembered that the patient may be having more than one clinical entity responsible for his or her symptoms. It is not infrequent for a patient to have TB and bronchiectasis, or TB and LIP, or LIP and bronchiectasis simultaneously. So you got a diagnosis, you are treating the patient with adequate therapy, still the patient is not responding, then think of co-infection or other factors which may lead to this kind of clinical scenario. So the neurological morbidities, HIV enters the, this is the pathogenesis. HIV enters the brain through the infected monocytes and T lymphocytes that cross the blood-brain barrier, directly invades the nerve. This is one of the virus which can directly affect the nerve tissue, may cause inflammation, degeneration, disruption of neurotransmission, vasculopathy and demyelination. And by this pathology, the changes usually happens in an immature brain, so the morbidity is more severe in compared to adults. This is very important. The route of transmission is higher risk of neurological morbidities in children with perinatal transmission. Severe immunosuppression in child results in high plasma viral load in blood and CSF. So these are the risk factors. And age of the child is very important. Highest incidence of HIV-related CNS manifestations occurs in first 2 years of life, with incidence rates of 9.9% in the first year of life and 4.2% at the second and less than 1% in the third year. So maximum chances of affection is first 2 years. And so at that point of time, if there is regression of developmental milestones, we should be very cautious. The presence of other comorbidities like prematurity, low birth weight, poor nutritional status, it helps in progression of the neurological abnormalities. So spectrum of primary neurological manifestations: HIV-associated encephalopathy, stroke syndromes, HIV-associated neurocognitive disorders, which can vary in severity from asymptomatic neurocognitive impairment to severe dementia. So what are the general principles of the management? It is a CNS involvement in CLHIV can be subtle, assess neurodevelopment and look for red alert in HIV-infected children, especially infants and toddlers, because previously I have shown mostly affected kids are less than 2 years. Follow a syndromic approach to identify the etiology. Neuroimaging can be very useful, preferably MRI, not CT. Early detection of HIV infection through systemic follow-up and evaluation of HIV exposed infants and timely attention is the key to mitigate the CNS insult. Most unfortunate part is that specifically if the parents are not infected with HIV, we do not think of these kinds of manifestations. And at that point of time, we diagnose the patients at a very late stage, and probably we have missed at that point of time a very valuable period where we should intervene, but we have missed the opportunity to intervene at the appropriate time. Effective antiretroviral therapy can prevent to some extent and reverse the neurological signs and symptoms. Like our patient, we have treated a patient with, and now the patient is able to do some neurological some works which needs more alert state. So now the kid is better with the antiretroviral therapy. So to some, it's not, I don't know, probably it's not fully reversible, but to some extent it's reversible. Neurological manifestations in younger children, it's global delay in achieving the milestones, static or regression of the milestones, acquired microcephaly, progressive spastic paralysis. This is very important. And pyramidal tract signs like basal ganglia dysfunction, ataxia and seizure. For the older children, slow progression or regression of learning milestones, attention difficulties, impaired cognitive functions, conversations, comprehensions, perceptions and motor activity. So this is a disease entity which is common in pediatric population. It is the most common CNS manifestations of the pediatric AIDS. It can occur in first few months of life, but at that time it's very difficult to diagnose it. may precede with signs of immune deficiency and other systemic manifestations of the HIV disease. It's diagnosed if CLHIV have any one of the following signs for 2 months in the absence of demonstrable positive organism. This is very important. Before, basically, this is a diagnosis of exclusion. If the patient is presenting with some localizing sign, if patients with some gait disturbances, if the presents with some abnormal behavior, first exclude the other causes. At least exclude the tuberculosis, exclude toxoplasmosis, exclude cryptococcal meningitis. After that, if the child is having the following signs like failure to attend or loss of developmental milestones. This is very important. Loss of developmental milestones or loss of intellectual ability. Progressive impaired brain growth demonstrated by stagnation of head circumference. Acquired symmetric motor deficit manifested by any two of the following signs: paresis, exaggerated reflexes, ataxia, gait disturbances. First, please don't forget the first 2 points. Attain or loss of developmental milestones or loss of intellectual ability and the stagnation of head circumference. So whenever you are examining the patient, and please try to measure the head circumference. CT scan of the brain may show cortical atrophy and bilateral vaginal calcification. MRI films show the presence of cerebral atrophy, cerebellar atrophy, calcification in the basal ganglia, and signs of attenuation of white matter. And most of the times it is bilaterally symmetrical in comparison with PML, which usually happens in elderly population. It is asymmetrical, but HIV encephalopathy usually in MRI you will get a symmetrical picture. And HIV encephalopathy, even when arrested by ART, leaves residual cognitive and motor deficit with significant impact on independent mobility and daily living. For that reason, I am asking, please think of it and intervene at the earliest opportunity. Frequent association with lack of nurturing, a poor social environment, and parental sickness contribute towards overall poor development of these children. Thus, poor school performance and dropping out of the school is common. Management, ART is the only therapy, and detailed evaluation is needed for children with developmental delay, poor scholastic performance, and behavioral issues. They will need a referral to a pediatrician and a psychologist as appropriate. So, few words about the other comorbidities. Cardiomyopathy. All components of the cardiovascular system might be affected during the course of HIV. HIV-related cardiac disease is multifactorial origin. Due to HIV itself can cause cardiomyopathy. Secondary infections like toxoplasmosis, like PCP, they will lead to cardiomyopathy. Other concurrent disease states, side effects of the therapy may lead to cardiomyopathy. Nutritional deficiencies, yet unknown mechanisms. DCM is most common cardiac complications of HIV infection in children and is an adverse prognostic indicator in patients with HIV infection. Zidovudine is also may lead to cardiomyopathy, although it's not very clear. And zidovudine-based ART should be monitored clinically for evidence of the cardiac disease. It is more common in child population. Early atherosclerosis may be a new emerging disease in HIV children. So what is happening? Previously, the cause of mortality in both adult and children population was related to the opportunistic infections. But as we are going through an era of very, very effective antiretroviral therapy, the life is going to be prolonged. So now we are experiencing the non-infective cardiometabolic or the metabolic complications of the disease and the side effects of the drugs, which usually happens and usually manifested by weight gain, dyslipidemia, and all other atherosclerosis and all these kind of things. PAH, pulmonary arterial hypertension. So it's defined as the resting mean arterial pressure greater than 25 millimeter of mercury or mean pulmonary arterial pressure following exercise. If it exceeds more than 30 millimeter mercury, then we call it pulmonary arterial hypertension. Basically, it happens due to increase in pulmonary vascular resistance or pulmonary arterial pressure. So the child presents with exertional breathlessness and inability of the right ventricle to raise the cardiac output with exercise. That's the problem. Usually the kid presents with a dyspnea, evaluate the patients. If you are not getting anything, think of pulmonary arterial hypertension. Other symptoms are hemoptysis, chest pain, congestive cardiac failure, dizziness, or syncope and arrhythmias. So chest X-ray may show cardiomegaly and pulmonary arterial enlargement. ECG may show right axis deviation and RVH, right ventricular extension, right ventricular hypertrophy. It is confirmed by other possible, if we are able to exclude the other causes of PAH, and all the children with signs of pulmonary arterial hypertension needs an urgent referral. Please do urgent echocardiogram for these kinds of patients. So I think it's done. You may get some repetition of my words because I think repetition. If I repeat some lines, it's easier to penetrate the words in your brain. So for that reason, there may be some repetitions. So thank you all for patient hearing, and I'll be happy if there is any questions like that. Thank you.
Thank you so much, sir. Participants can unmute their mic and ask the question if you have any questions.
No questions.
Yes, sir. No question in the chat box as well.
Okay. Okay, then thank you. Then I think we can end it up.
Thank you, sir. Thank you.
Thank you.
Can you conclude the session now?
Thank you.
Okay.